To kickstart the discussion, I'd like to ask one question to Dr. Alejos regarding your criteria for donor and recipient size mismatch, because that's often an issue in our pediatric population. If you're trying to get as many hearts as possible, it's just not possible to match them for size. Children waiting on their transplant list grow, and so what is your cutoff for size mismatch between donor and recipient?
I mean, I think you really have to take that kind of on a case-by-case basis. I think we work with, our surgical colleagues. I mean, there's a question of fit. I mean, a lot of the children who have dilated cardiomyopathy, obviously, their own hearts have swollen and grown, leaving a lot more room for a bigger heart to be implanted. But we have to take into consideration things such as their hemodynamics, the kind of workload the new heart is going to have to do. So, I mean, in general, I think the smallest in terms of weight would be probably 90% of the recipient in the ideal cases, but most likely I think we'd like to always take a heart from at least an equal weight or greater, as much as that will allow. So, I mean, but I think that's, I mean, as you said, it's an important question.
Thank you. Do you want to proceed with your questions?
I think so. She may want to ask a question first.
I have a question about how you handle a patient that needs a heart and lung transplant, given that it appears that the lung transplant candidates are listed in a different way than cardiac transplants are listed for emergency surgery. Has there been any improvement since my very terrible experience of about 10 or 12 years ago, where I could get a young woman on a heart transplant list, but I could not get her on the lung transplant list? She had Takayasu disease.
Well, right now we don't have a pediatric lung transplant program at UCLA. It's something that we're actively pursuing. And once we have that, then the heart and lungs will be something that we'll also pursue. The issue is that when after the patient's transplanted, the survival is based more upon the lungs than the heart, so it's a little bit different. But all over, there's only a few lung transplant programs in the United States, and it's difficult because the volume isn't high. So there's a lot of institutional support that needs to take place before we can do that. But something we're actively pursuing, and hopefully in the next year we'll have something like that.
I think programs in general will evaluate for, if the need is for a heart-lung, the evaluation for both will go on concurrently and decide, I mean, that both of them, if the agreement by both teams is that they need to be a heart and a lung, they'll be listed for both organs at the same time.
Although I will say, working closely with Dr. Ardehali's lung transplant team as one of the cardiologists, there's a lot of patients who are referred with the idea that they have irreversible ventricular damage and heart failure and require both a heart and lung transplant, including some congenital patients, when in reality many of those can undergo successful lung transplantation as long as they're on the right cardiac meds. And they can undergo certain reparative procedures that make them a better lung transplant candidate. And the idea that a dysfunctional right ventricle, for example, in somebody with severe pulmonary hypertension means that you need a heart and a lung transplant. I think our experience, and I think Dr. Ardehali is probably going to speak to this, is that many of these right ventricles will recover once you put in functional low resistance lungs.
I agree with your comments, but in reference to your question about the organ allocation, if a patient needs a heart and a lung, they're evaluated by both teams and they're listed for both organs. If an organ by UNOS is allocated to the recipient based on the heart, based on the priority of the heart, then the lungs will come with it. If they're allocated based on the lungs because of the priority of the lung, the heart will come with it. So that is how UNOS is dealing with patients with dual organs.
So I have a question from the audience. So the question for me was, Is the Impella RP intended for use in RV dysfunction in the setting of biventricular dysfunction, or can it be used in isolated RV dysfunction? And it can be used in isolated RV dysfunction. It is, it's just, it can be sitting in the right side of the heart and unloading the right side of the heart as in isolation. But I think the most attractive indication for us at UCLA will be those patients that get left ventricular assist devices, for instance, like a HeartMate 2, and who end up having RV dysfunction. And this device, the Impella RP, can be used as a recovery device to allow the RV to rest and to recover. So I think that's going to be our most attractive indication from our standpoint.
Just a corollary on that question. What is the size of the vessels that you need in order to implant an Impella?
It's an 11. It's 11 French.
11 French. So it would probably not be useful in the pediatric population.
Depending on the size of the pediatric patient, yeah, it could potentially be used.
Thank you.
I have a question that says, if a child receives a heart transplant, when or how many years after will they need a reoperation or redo transplant? And obviously that's variable and patient dependent and dependent on a lot of factors from a standpoint. But if you look at all the data, it's about 80% at 10 years of graft and patient survival. And so there's probably about 20% of patients during that time. But we do see patients, not all the time, but we do see patients that will need retransplants soon after, 3 or 4 years after transplant. It's because of their antibody production and just the way they've performed if they've had rejection episodes. And there's a 10% attrition every year because of chronic rejection as well. And so, again, it's dependent on a lot of patient factors, both pre-op as well as post-op. But I think it's something that we're ever improving because of our immunomodulation, as well as just learning how to do this better.
In the same setting, do you think that for these sensitized patients, the total artificial heart has any role in acting as a bridge to potential future transplants after desensitization therapy?
Yeah, I think the biggest problem with that is desensitization therapy, which isn't very effective, unfortunately. But I think that's going to be an excellent bridge for someone who has biventricular failure and maybe an end stage where they're sent home just with the device without transplant. So that's something that I think is in the future, and that we have to look at destination therapy as a possibility.
Dr. Deng?
I would like Jamil and Lee to comment on the question, what would you recommend for referring colleagues on our joint congenital heart disease, heart failure program? What kind of timing for referral would you recommend?
So we've developed a multidisciplinary clinic where we have a congenital specialist, heart failure specialist, where we evaluate congenital patients who might be in the future needing a transplant. I think that the universal agreement is that the earlier the evaluation, the better. Introducing patients to the team, introducing them to the process, I think is essential.
Yeah, I agree with that, but I also think that it's best for us to see patients, frankly, when they're healthy, to make sure that we do everything possible to avoid the situation where they end up coming in florid heart failure with severe pulmonary regurgitation, for example, in tetralogy patients that has been underappreciated for 25 years. And then we get a patient who has a failing right ventricle and really doesn't have many options outside of, assist devices or transplantation. So I would urge that the referral be made at a much earlier time, with the idea that we co-manage many of our patients with the local referring doctors. We cannot, as a quaternary institution, manage every single patient for 1,500 miles radius here around the southwestern United States. But what we can do is build alliances and understanding with local providers where we can maybe see the patient once every few years and say, okay, well, this patient's doing well. This pulmonary valve is continuing to work here. Just continue to do yearly echoes, send us the studies, we'll take a look at them. What we don't want to do is wait until the patient is so ill and now has multi-organ failure, and then it's, well, you know, you have no other options. So I would say that it's somewhat of a failure of the system if we're seeing the patient at that point. It would be far better for the patient and for everybody involved if the patient could be referred at an earlier time point in their care.
In the same vein, I would like to ask you, I mean, your patients, the female patients who grow up and want to get pregnant, what kind of counseling do you do, and what is the risk of heart disease in the children of these female patients with adult congenital heart disease?
Absolutely. As we mentioned, I think reproductive counseling early on is important. We've found there's a series of publications regarding the risk of transmission of congenital heart disease. Unfortunately, we don't, outside of specific syndromes such as Down syndrome, DiGeorge syndrome, it's a little bit more multifactorial in terms of the transmission of congenital heart disease. If you have a more severe form of congenital heart disease, we think the risk is around 8 per 10,000 births. Other literature seems to suggest that the risk of some form of congenital heart disease being transferred is about 3%. So we try to give women a whole spectrum, but we also try and place it within the context of their own personal risk factors. I think discussing things such as contraception and pre-evaluation prior to having a pregnancy is essential for these patients in terms of, as Dr. Abelholsen mentioned, you know, there's short-term risks and long-term risks, and I think patients need to understand that from the beginning. And also patients with specific shunts, they have a variety of risks based on the type of contraception. So we have specialized nurses, Pam Miner, who's in the back, and Linda Hauser are experts in this, as well as the nurse Mary Canobio that works with me on the pediatric side for transition. So we try and really address these issues early and try and prevent complications in patients just coming in pregnant later in the game.
Yeah, I mean, I agree. There's a game plan in place for every pregnant patient, multidisciplinary team meetings. There's a delivery plan. We see the patients every trimester. Every woman gets a fetal echocardiogram to look at transmission to the fetus. And it takes really that kind of team and that kind of planning to ensure the best possible outcomes. And that's not even mentioning the pre-pregnancy planning and consultations and such. But, you know, then this is why it's really important to actually see the patient before they get pregnant, to do an exercise stress test, to look at the echo, to make sure that we give them some sort of, you know, risk stratification and then let them make their own decisions thereafter. So this is a really important area. You know, women should be aware that you know, depending on the condition, there is a risk of transmission that can be as high as 15-20%, for example, for congenital aortic stenosis. So depending on the type of condition and how much penetrance there is in a specific family, you know, the risk may change. If the mother and the father both have congenital heart disease, you know, they went and they met at the Camp del Corazon and they fell in love, you know, and they come in, what's the risk that our child may have a congenital heart problem? Well, then, you know, you're shooting up above 50%. So all of that needs to be, you know, discussed, and that's where having a multidisciplinary team and the kind of support that's necessary to take care of these high-risk patients. You know, this isn't a kind of operation that can be run out of a single clinic with a single provider. And that's the reality of it. You know, you need multiple levels. You need the nurses, the nurse practitioners, the physicians, the social workers. And that is, you know, a really important take-home message. So for institutions that are thinking of getting into this and doing this kind of thing, you really need all of those support services. And the physician, frankly, is probably the least important component.
Thank you, Jamil. Dr. Alejos, do you want to answer the question?
Yeah, I have a couple of questions here. One is, does the transplanted heart grow at par with the patient's growth? Interestingly enough, I mean, it does. Actually, in some of the young children who have hearts that are oversized for them, that heart won't grow until the child actually catches up to it, and then the heart will continue growing with it after that point in time. But the heart will grow. I mean, with the child, we have some patients who are transplanted as infants and are 20 years out from transplant, so still with the same heart. What is the frequency of transplants and what is the earliest time of transplantation? I mean, transplant is not, a common occurrence. I mean, basically a center that can do, as much as we do at UCLA, between 15 and 20 a year, and pediatrics is probably one of the busiest programs in the country. That is how rare transplantation is. I mean, it's becoming, the need for it is increasing, but that's all a reflection of the fact that, our congenital heart surgery has actually become so good that a lot of children who would have died in infancy are now living into, adolescence and young adulthood. The earliest time of transplant, technically we can list patients at 36 weeks gestation, so even before they're born, because in some cases when if a heart becomes available, if it's a severe defect that has been diagnosed in utero, that patient the baby can actually be delivered at 36 weeks and transplanted at the same time. So delivered by C-section in one OR, moved to the other OR and undergo a transplant at that time. And that's the youngest that's done. That used to be done more, or those patients used to be listed at that age more for severe congenital defects like hypoplastic left heart. But now, as other options, more non-transplant options have improved significantly, that is happening less and less. And I think the last question, I think we kind of answered, can an adult heart be transplanted into a child based on size? I think children or pediatric patients under the age of 18, or actually donors under the age of 18 will go by priority, will go to a pediatric patient first. So that's really the only delineation. Other than that, it's basically all the transplants, the donors are basically done by size. So young, small adults, donors potentially could go to a pediatric patient. It really is not real. We obviously, when we get phone calls about potential donors, we take into account the age of the donor, as well as the cause of death and whatnot. But the age obviously plays a role into our decision making, but there is no regulation or criteria in terms of how old a donor can be for a pediatric patient. It's more based on size and blood type. So.
Thank you. Any other questions?
You want to do our questions?
Oh.
You do.
Yeah.
Sure. There's a couple of questions here. One is prolonged cyanosis causing increased red blood cells versus anemia of, I'm assuming this says heart failure, anemia of heart failure. And then the second one is, what do you see in patients with adult congenital heart disease with late CHF, and how do you manage it? Well, this all kind of ties into itself. So here's the problem with having one approach to the adult with congenital heart disease. This isn't cystic fibrosis, this isn't ischemic or non-ischemic cardiomyopathy, and this isn't just valvular heart disease with 4 valves that can either be stenotic or regurgitant. It is hundreds of permutations and variations. Holes here, transpositions, single ventricles, upside down ventricles, dextrocardia, Fontan, not a Fontan, a Glenn, not a Glenn, a BT. So you can't cut this topic with one blade. It is not going to work. But the take-home message is that cyanosis or erythrocytosis, not polycythemia rubra vera, as many people call it when they see high red blood cell counts in patients who are cyanotic, but erythrocytosis in someone who's blue is an appropriate response to them having low oxygen saturations. Their erythropoietin levels are going to be high, their bone marrow is going to produce more red blood cells, they're going to need more iron to produce those red blood cells. And so that's a compensatory appropriate mechanism. So attempting to take a patient who has a hematocrit of 65 or 70% and bleed them down to a more normal hematocrit of 45 or 50% if they're cyanotic is actually exactly the wrong thing to do and can worsen symptoms, increases the stroke risk, and can actually worsen heart failure in these patients. So you want to be very judicious about trying to bring down people's red blood cell counts if they have cyanosis. You also want to be very judicious about using iron because you also don't want hyperviscosity symptoms. You don't want their blood to be so thick and flow through their venous and arterial system to be so slow that they end up having symptoms of hyperviscosity, which can very much mimic strokes, long bone pain, those sorts of things. So it's a little bit of a walking a fine line in how you can manage these folks. As far as what we see with congestive heart failure and adult congenital heart disease, well, all sorts of things. But frankly, depending on the type of congenital heart disease they may have right heart failure, left heart failure, or a combination of the two. And if they have a single ventricle, well, they probably have both. And how do we treat them? Well, we treat them with the medications that other heart failure specialists use. But again, we have to have a nuanced understanding of their anatomy and physiology, which is why, adult congenital heart disease actually has hit the big time this year, because we now are going to have a board certification that has been approved by the American Board of Pediatrics and the American Board of Internal Medicine. And it's going to be a 2-year fellowship in addition to regular cardiology or pediatric cardiology training. So frankly, the answer to this question is you kind of need to do a 2-year fellowship. And you should probably refer the patient so that we can give a nuanced and appropriate consultation and advice.
Thank you, Jamil. Are there any other questions?
So there was one more question that was written, and it said, dentists will state that no prophylactic antibiotic premedication is the standard of care. Please comment on this issue with heart patients seeking dentistry care. So this is a pretty broad question, and I'll open it up to the whole panel, but in 2007, the ACC-AHA revised their recommendations for the need for prophylactic antibiotics in situations of predictable risk. The initial part of the paper spends a lot of time sort of detailing the number of exposures to bacterial flora from our oral pharynx and such in our normal daily activities, everything from brushing our teeth to eating a hard bagel to half the things that we've done in the back room in terms of having coffee and stuff. So I would really direct you to Table 2, which is on the 3rd page of those guidelines, and essentially patients who have prosthetic material, who have mechanical valves or tissue valves, or who have residual congenital heart defects, who have cyanosis, are the ones that particularly still need to have antibiotic prophylaxis. There's been a lot of people who have been more liberal with their prescription of antibiotics, including patients who have bicuspid aortic valves, who we still see a handful of patients, up to 3 to 5 per year, who come in with endocarditis who no longer fit within those recommendations. There's been a couple surveys, and it looks like the practice of this varies the whole spectrum. Some people who have really restricted antibiotic prophylaxis in dentistry situations, and people who are much more liberal. So ultimately, it comes down to your own comfort level, and if you're unsure, then really, particularly in the adult congenital population, it's worth seeking the advice of somebody who has more training.
Thank you very much. I think this was a very interesting discussion, and thank you for attending most of it. Lunch will be served in the west side room, so please proceed outside to the left and down the hall, and our staff will direct you where to go. Thank you very much.